I'll take option 2.
Y'all gonna owe him some stuff, man.
We already do, but we can't pay him the amount that we owe him.
I know. He's going above and beyond. I appreciate that. All right, so we left off. Is it all right for me to start? No? Well, while everything is downloading, let's take a minute to re-emphasize Henderson Hasselbalch. And why is Henderson Hasselbalch so important with local anesthetics? Todd.
Depending on what the PKA is, will determine whether or not it will be found more in the anesthetic environment or not.
Okay. He said the PKA is going to determine what's going to be charged and uncharged, basically. And why do we worry about that, Monica?
Because charged is going to go, or is not going to cross the liver membrane.
Okay. But what is it about the charge that we need to happen?
We need for it to be fit into a specific receptor.
So, what is she trying to say, Jesse? So it has to be uncharged, she says, to pass, but then she said it has to be charged to bind to a specific receptor.
You need the local anesthetic to go into the cell membrane, then charge, then go back up to block.
All right. And so it's going to charge itself again in the cytosol, this base, right? It's going to grab onto a hydrogen, become a BH+. And Robert, what domains could it bind to on the sodium channel? Give me one of them. Nope. They're numbers. So there's 4 domains. How about this question? Which one do local anesthetics not bind to? 2. So 1, 3, and 4. Mr. Golder, what segment on those domains does it bind to?
I'm not sure, sir.
Okay. Anyone? The 6th segment on domains 1, 3, and 4. All right, let's hit the cocaine now. So we got about 60 slides. There's going to be some information that's only for your information. I will highlight what you will have to know. And again, don't read all of these slides. Trust in what I say. And I promise what I say is going to be on the test. Now you may have to understand conceptually, as you're learning about me, that it's not always that obvious. It's not always the first answer you see. Sometimes it is, but not always. What's that?
Sometimes it's the zebra.
Sometimes I get you with the distractor. All right. And there's a reason for that. There is an academic purpose for that. All right, let's talk about cocaine. Cocaine is one of the first things that came out, and actually the person that was experimenting with this, Carl Kohler, became addicted to it.
Whoops.
But it is a very good local anesthetic, and it's a very good euphoric agent. When you take this cocaine, you inhibit the uptake of catecholamines, one of them being dopamine, and you stimulate the rewards pathway. And for that reason, this is a very commonly abused drug. But think about what it does. And think about it as an anesthetist. This causes vasoconstriction and gives you great anesthetic properties. Is there a surgical subtype that you could see this being used in? Nasal, right, exactly. So you're going to see these cocaine pledgets, and as an anesthetist, you might get it in your box or it'll be in your Pyxis, and it comes as a 4% vial typically. And then you hand it over to the ENT surgeon. He puts it on some pledgets and puts it in the person's nose. He waits, and the person vasoconstricts in the nares and also gets numb. And then you sedate the patient, and you see him whacking on the nose with that mallet of his, and you're like, oh, that's so nasty. What do you think is going to happen to blood pressure when he puts those pledgets in? It's going to go up. What's going to happen to heart rate? It's going to go up.
Can you spell that word you're saying, pledgets?
Pledgets. Pledgets. That's like, it's a fancy name for a cloth wrapped around a stick. Pledget. So you have somebody with CHF or coronary artery disease, and you hand the cocaine to the ENT surgeon. Do you foresee a potential problem? Ms. Helmrich, I give a beta blocker with cocaine with somebody with CHF. What's my problem?
You see an increase in blood pressure, increase in systemic vascular resistance,
Yeah.
but a decrease in your squeeze and hypertrophy of the heart.
Okay, got it. So she's got it right. So you're going to see an increase in SVR afterload in the presence of a beta-1 blockade, decrease in force of contraction, inotropy. So, Matthew, sir, in envisioning that, what do you think happens to the heart? You've got decreased chronotropy, decreased inotropy in the presence of increased afterload. It's going to start backing up, right? What's that called? Congestive heart failure. Now, if you're young and you are studly, not like me, right? You give it to a young guy and you see ST changes. The person has no health problems. It's quite possible you can see ST changes that are indicative of ischemia. Well, that might be indicative of an acute coronary vasospasm. Now, cocaine is a C captain ester, so it's broken down by esterases.
What is that supposed to mean?
Captain ester?
Yeah.
Cocaine, chloroprocaine, procaine, and tetracaine. All, captain ester. Broken down by esterases. And double IMI. If it has two I's in it, it's broken down by the liver. Yeah. Huh? Yeah. I'm telling you, this little laptop right here works wonders. So, again, cocaine has a place in ENT surgery, especially nasal surgery. Now, imagine you don't have cocaine. How can you get both effects? And the answer's on your screen. You could use another local anesthetic combined with neosynephrine. Neosynephrine, also known as phenylephrine, has that alpha-1 agonism, give you your vasoconstriction, and then you can get your sodium channel blockade properties from your lidocaine. Now, looking at that congestive heart failure patient again, or maybe not even that patient, the patient with severe CAD, where tachycardia is not a good thing. And you need to anesthetize the nose. Why is the lidocaine with phenylephrine a better combination? Anyone think you might have the answer?
It's not systemically absorbed.
Okay. Nope, has to do with the actual catecholamines. On cocaine, I am inhibiting the uptake of norepinephrine, dopamine. What are those inherent problems on the cardiovascular system? Vasoconstriction, no doubt, but what else? Tachycardia from the beta effects of the norepinephrine. If I just give phenylephrine, what's the only receptor I'm stimulating? Alpha. And actually, I might do what to heart rate?
Decrease it.
How?
Baroreceptor.
Baroreceptor-mediated decrease in heart rate, which might be better for that patient. If you remember back to the volatile lecture, you'll remember that if we were to use an inhalational agent, that there is a potential for arrhythmias. We spoke about desflurane and halothane. If you see the occasional ectopic beat after giving cocaine, don't fret. As long as the hemodynamic parameters are normal, you may see occasional dysrhythmia with the use of cocaine. And why is that? Because it is blocking the uptake of dopamine and norepinephrine. Any questions on cocaine? Use in basal surgery. Be careful with patients with cardiac disease. Look for an alternative. The next ester that we're going to talk about is chloroprocaine. Has a very rapid onset, even though it has the highest pKa. And why is that, Tristan? It's got a quick onset, but it has a high pKa. What do we do when we give this?
Concentration.
We give a ton of it. We give a boatload, crap ton. We give 3%, right? Now its half-life is 21 seconds. If its half-life is 21 seconds, what does that tell you about its toxicity? It's not very well protein-bound and has a short half-life. You think it has a high toxicity profile or a low toxicity profile? Low. It's not highly protein-bound, and it's chewed up quickly. So we can use lots and lots of it. Now that plasmacholinesterase deficiency rears its ugly head again. So that clinical scenario might come back to visit you in asking you about chloroprocaine. So this is a drug that you give, and if it's for emergency C-sections, for example, it has a quick onset and a quick offset. Okay? About 45 minutes, you don't have to remember that, but it's not going to last very long. And why is that? Its half-life is 21 seconds, and is it highly protein bound? No. Absolutely not. Now, there's a couple problems with this. You will use this for regional anesthesia, especially in the OB suite. But you cannot be surprised if afterwards that you see a patient complaining of back pain. It has a chelating agent in it. Does everyone know what that means? A chelator will bind up calcium ions. Okay? Now envision that. You're taking all of the calcium ions away from the area in which you injected it. So that particular area becomes hypocalcemic. And if you remember from a long time ago, I don't know when you may have learned it, but hypocalcemia will cause tetany, will cause muscle spasms. And if those spasms continue long enough, you can see why you would get back pain.
So chelators bind up
Calcium.
So you end up with hypercalcemia?
Hypo.
Hypo, okay.
In the area of injection.
So what was the name of the metabolite?
It's not a metabolite. It's EDTA. For those of you that have worked in the lab, does that sound familiar? Yep, purple tops. Is it purple tops or blue tops? Both, isn't it? Anyway, it's the peppers and blue tops. It's in one of your things, all right? Damn, I can't remember that. Now, if you get somebody that says, "Sir, ma'am, my legs hurt," not my back, my legs hurt. I'm feeling this stinging sensation. There's also, in some formulations, a sodium bisulfite that if you inject it into the epidural space and it finds its way to the nerve root, it could cause some neural irritation. And that could present as paresthesias or pain down the legs or the area that you've injected it. because you will use this for regional anesthesia as well. Now here's a couple clinical correlates. Many of you have taken care of patients who've received Duramorph in a spinal or an epidural, correct?
Is that Dilaudid?
Or Dilaudid. Dilaudid is hydromorphone. So we can have Duramorph, which is morphine, or hydromorphone. But if you use Nesocaine, otherwise known as chloroprocaine, you're going to see that your effect of your opioid is severely diminished. It appears that chloroprocaine may have some mu2 antagonist activity, mu2 being an opioid receptor. As well, many of you will learn clinically to mix chloroprocaine with bupivacaine to do your peripheral nerve blocks. Why do you think they're having you do that?
Shorten the length of time Bupivacaine works.
No, that's a result.
Can you repeat the question?
Sure. You're working with the ortho surgeon that day, and you want to get your blocks, and you want to have your turnover not affected. So you're going to mix chloroprocaine with bupivacaine to do all of your interscalene blocks, all of your shoulders. Why do you think you're doing that? Post-op pain control, but what does the Nesocaine do for you? Quick onset, right? You can get in the room. The shoulder will be numb. You won't have to wait that 20 minutes for the bupivacaine to set up. So can you see why they would do that? Now, does it greatly decrease the length of bupivacaine? I would say that depends on the patient, because I routinely do that. I routinely will mix chloroprocaine with Marcaine, and I get up to 18, 24 hours of post-op pain relief, but I still have my quick onset from the Nesocaine. Okay? Will you ever do that in an epidural? No. This is for peripheral nerve blocks. Any questions on chloroprocaine?
So it decreases the duration of bupivacaine?
It does, in some studies. But will that keep you from using it? Not necessarily, in a mix like that. Yes, ma'am.
EDTA was the
Chelating agent for calcium.
sodium bisulfate.
Sodium bisulfate is something totally different. Sodium bisulfate is a nerve irritant. It will cause you to experience paresthesias and or pain. And in some cases, even urinary incontinence.
So you get both of those preservative processes? Or are they mixed? Are they separate preservatives depending on?
Some vials you get may have both. Some vials you get may just have one. Yes? 2-chloroprocaine is also called Nesocaine. Nesacaine. Nesocaine. Procaine. This is something that you will never use. But guess what the clinical concern is with it? PAVA. And where might PAVA be found in other solutions? Cosmetics, suntan lotion. Here it is. Take a good look at it, and it's gone. Tetracaine. Tetracaine is an ester, but this particular ester, even though it's chewed up by esterases, has a long duration of action. And it is also what for you military folks? It's very stable in storage. Why? Because it's a powder. It's a powder, and it works very well when you reconstitute it and use it for a spinal. You'll get a very long block.
How does it use a short plasma half-life? They get a long duration of action. It's counterintuitive.
So this has got a half-life up to 4 minutes. Okay. Now imagine that the dose is going to be related to that as well as protein binding. Just because if it's free in the plasma doesn't mean it's not still bound at the receptor. So you're talking about your binding kinetics, that this has a very high protein binding.
So, in the,
And it has, it's very lipophilic too.
so that protein binding would increase its availability, which would make sense in terms of the slow onset.
But it's duration of action. Protein binding is directly related to duration of action. Now, just because it has a short half-life, that's going to be accounted for by the clinical dose that has been calculated and effective. So these doses have all been done for years now. This is what we know we get clinically, even though that plasma half-life is short. And because that half-life is short, what does that do to its toxicity? Decreases it. So you can do what with the drug? Give more. Now it's used very routinely for spinal anesthesia. Tetracaine is in the powder, and I urge you to use it when you're a student. You can get a 5 to 6 hour block if you use epinephrine with this. For those of you going to William Beaumont and working in the GU suite on Thursdays, that might help you. Now, how can you reconstitute this? A very simple way is to, once you make your dural puncture, extract some CSF. You'll have this powder. You will extract the CSF. You will inject it into your vial, mix it, withdraw it, and re-inject it back into the spinal needle. Or you can reconstitute it with dextrose or sterile water. But what do you have to remember when you're reconstituting this in a spinal? Huh? Porosity. So I'm 8 to 10% dextrose. Am I hyperbaric, hypobaric, or isobaric? That 10% dextrose is hyperbaric. So I inject it. Where does it go? Patient's sitting up. Straight to the butt. Okay. I am CSF. Am I hyperbaric, hypobaric, or isobaric? Iso. I'm sterile water. Hypo. So now you're sitting up. Where does it go? Straight to the top. Tetracaine can also be reconstituted, and it can be used as a great topical anesthetic for when you want to do a airway block for an awake intubation. Problem is, it lasts a long time, and your airway reflexes are gone. So what do you run the risk of if you have no secured airway?
Aspiration.
Right? Regurgitation and possible aspiration. Now, just so I'm clear, that you're clear, do we understand the difference between regurgitation and aspiration?
Yes. Regurgitate and just throw up.
Regurgitation is just contents in the throat. You brought them up from the stomach. Aspiration is that you've actually inhaled them into your lungs. So make sure your speech is always clear. Just because you regurgitate doesn't mean that you aspirate. However, if you see someone that's regurgitated without an airway in, what should you do post-op? That's right, get a chest x-ray. Now, Justin brought this up the other day. Check out Benzocaine. Benzocaine is a topical, you may know it as hurricane spray. Comes in that yellow can, stinks to high heaven, and you spray it on the back of the throat, and it does absolutely nothing to take away the gag reflex. But look at its pKa. This is a weak base. Right? A weak base that has a pKa of 3.0 or 3.5. And we're putting it into a pH of what? 7 roughly on the mucous membranes. So it's going into a more acidic or less acidic environment? Less acidic. Less hydrogen available. So ideally, this should be readily available in the basic form to pass through membranes. My experience with it is it doesn't seem to work that well. Now, because of its pKa and because of some other issues, it's limited to topical anesthesia. The question you'll have to be concerned with is what is its side effect? methemoglobinemia, especially in pediatrics. So excessive sprain will give you methemoglobinemia. And what's the problem with methemoglobinemia?
Hypoxia.
Hypoxia, because it doesn't do what?
Can't find oxygen.
Yeah, methemoglobin will not carry oxygen. So the clinical scenario is you're going to perform an awake intubation and you want to use hurricane spray to attempt to remove the gag reflex, and you've excessively used it on this adolescent patient, and now the patient is beginning to desaturate. So what happened?
Give a toxic dose.
You gave too much and you had methemoglobin build up. So that's benzocaine. Now let's move on to lidocaine. We're going to talk a little bit more about this one because you're going to use it a lot, like chloroprocaine. This has a pKa that's pretty close to physiologic pH. So what does that tell you, Jeffrey?
50% of it can be absorbed readily.
So a lot of it's going to be uncharged as soon as you deliver it, right? And this is routinely used with epinephrine. Why would they do that, Katie? Or Catherine? Okay, so that extends its what? Duration of action. Excellent. So many times you're going to use lidocaine with epi, and it's going to come pre-mixed like that in many occasions. So by itself, it's got a pretty quick onset. You add bicarb to it, and you're going to increase its onset. Why did you do that, Jennifer? If I add bicarb to a local anesthetic, to the solution, what have I increased? No problem. What do you think, Stacey? I get bicarb to a local anesthetic in a vial. What have I increased? It doesn't. It doesn't change the pKa. But it does make the environment more basic. And if it's more basic, it has less hydrogens to bind to the base, so you have more in the B form. Right? So all you're doing with that bicarb is adding it to the environment to soak up all of the hydrogens, to have more of the B available by itself. And the B by itself does what? Passes membranes. Everybody tracking there, or are we still kind of...
I did miss one point. When you mentioned there was a pKa a couple of drugs ago, it said 3.45, and you said weak base.
It is a weak base.
When I see that number, I'm thinking weak acid. So what point am I missing on
It's
that?
pKa.
It's
3.5.
Your pKa does not determine whether or not you're a weak acid or a weak base. Your pKa is an independent characteristic. Your ability to be a weak acid or a weak base is going to be defined by what? That's right. Whether or not how well it will accept a proton.
So how would I know that? You said weak base, and I don't know how I would have known that.
Here's what everything you give except for your induction agents and hydralazine is a weak base.
You know it's a weak. You know it's a weak base.
Yep.
Okay.
There's no weak acid local anesthetics. Yeah. Okay. What makes it its configuration, where its polar bonds are.
So in relation to this scenario, so it makes them now the lidocaine gives off this conjugate acid. So
Check.
And it goes in.
It's all base by itself. And that injection, you got to remember that environment is injected at the same time as the local anesthetic. So that basic environment gets injected into the tissue to soak up your body's hydrogen ions. So wherever you injected it, you have less hydrogen ions, more free local anesthetic, more that will cross lipid membranes. Right? But that's just part of it because it has to recharge once it's in the cytosol and then bind to domains 1, 3, and 4 on the segment 6 on domains 1, 3, and 4. Right?
So when it's charged inside a membrane, how do you get it out of the membrane?
So what do you know? You see this formula B plus H plus is equal to BH plus. Is that just a one-way? No, it's two ways. So that's always going on. Combination, and then unionizing, and then deunionizing. Always going on. Now, one thing about lidocaine that you may not have realized, and I didn't know until I got here, was that lidocaine actually has a seizure-genic metabolite. And so, many of you may have pushed this, but if you push it enough over time, you could possibly induce a seizure from this metabolite known as MEGX, monoethylglycine xylidide. Monoethylglycine xylidide, MEGX. So long-term infusions of lidocaine, just be careful. Have I ever seen this? No. But this is in the literature, so it is an academic point. One thing that's interesting is acidosis. Acidosis increases toxicity. When you're acidotic, what do you have more floating around in your plasma? Hydrogen. Now, are plasma proteins positively or negatively charged? Negative. So, a negative plasma protein in the presence of hydrogen ions leaves no room for other positive ions to bind to. And when you inject these local anesthetics, they result in two forms: uncharged B and charged BH plus. It's the BH plus that binds the proteins and receptors. So in your plasma, if you're acidotic, you've already got hydrogen in the way, and now you have more free fraction of your local anesthetic. Does that make sense? Now, several years ago, historically we've been teaching the hyperbaric lidocaine problems. So it used to be that if you used hyperbaric lidocaine, especially if you used it with microbore catheters into a spinal anesthetic, you could run into problems with transient neurologic symptoms, or also known as transient radicular irritation. Does that preclude you from using lidocaine in a hyperbaric type of way? Let's say you want a saddle block? No, it doesn't. But there are case reports of it. If you were with me in the OR, we would use hyperbaric lidocaine on a couple occasions. Do I routinely do it? No. Why? Anybody have a theory why I don't do it? Because when I open up the kit, I don't have hyperbaric lidocaine in there. What do I have? I have hyperbaric marcaine. And that's what you use. You use what's in the kit. But think about hyperbaric lidocaine. Where is it going to go when patients are sitting up? Straight down and into the sacral region. And what do we know that region is responsible for?
Bladder.
Micturition, defecation. And so when you get these transient symptoms, you may see incontinence, right? You may see paresthesias down the legs. And so you'll be expected to understand what TNS is. You'll also be expected to understand what transient radicular irritation is. Because of the hyperbaric lidocaine. Hyperbaric lidocaine. And I want to make sure you understand this. Not only is it just the hyperbaric lidocaine, but I thought I had it on here, maybe I do later. But these transient symptoms have also been associated with the use of microbore catheters, very small, much smaller than epidural catheters, used for continuous spinal anesthesia, even with regular lidocaine. So there's two things that you have to understand about these transient neurologic symptoms. There's case reports of it with hyperbaric lidocaine, and case reports of it with the use of micro-bore catheters that are much smaller than epidural catheters, and the use of regular, non-hyperbaric lidocaine.
Why is that, sir?
Why, I have no idea why that is.
And is that both of them or just the transient neurologists?
These are, they're synonymous. If you hear TRI or TNS, it's the same thing. Right, you won't even see those catheters anymore. You will not see those catheters anymore. The reason I bring it up, though, is you might see that on some type of certified. Now, who here has seen a beer block? Okay, named after August Beer. It's when you have the patient have an IV in the area that you're going to do the surgery on. You then exsanguinate the arm. You put your tourniquets on, and then you inject the IV with local anesthetic. As you traverse the venous system, it diffuses and it binds to the nerves and causes a regional anesthetic. That's a beer block. So lidocaine is used very often with these beer blocks. And you'll get about an hour, a little bit over an hour on average of an effect. And you'll see this with hand surgeries, a beer block. Interestingly, when you let the tourniquet down after 60 minutes, the effect's gone. But what happens if the tourniquet fails in the first 10 or 15 minutes?
Cardiac.
You have potential for cardiovascular problems. Potential. But lidocaine is a relatively safe drug because it's got a large CC to CNS ratio. And what do you know about its binding kinetics? I may not have told you this. But it's only bound to the receptor for less than 10 seconds. It'll bind, unbind, bind, unbind. So it's got a very short kinetic profile, binding profile. These doses, again, I'm going to peruse through them because I don't care that you know them from my class. This is just if you want to get an idea how it's used. What dose and how it's used. And if you have further questions on that, come see me. I'm more interested in clinical situations and when you would use a certain drug and when you wouldn't. Many people here use lidocaine as an antiarrhythmic, and I think you get a better appreciation of why now. We talked about the excitable tissue in the heart, and we talked about inactivated sodium channels. But you also use it to suppress reflexes like coughing. Fabiola, why would it suppress coughing? Go ahead, Christy, I know you know this. What's the afferent limb of your gag reflex? The afferent limb of your gag reflex. Cranial nerve what?
9?
Isn't it 9? Yes. Cranial nerve 9. So if you can inject that IV lidocaine, you're going to have a high concentration systemically, and some of it's going to hit your nerve endings on your glossopharyngeal nerve. And so your sensory stimulation around your larynx is decreased. Don't forget what local anesthetics do. They numb things up, both efferent and afferent. So if I can suppress coughing, what can I do at the beginning or the end of a case? I can suppress the gag reflex, the ICP increases, right? And I'll increase my style points with my staff. Look at that smooth extubation, no coughing whatsoever. I love lidocaine at the beginning. I'll use 150 to 200 milligrams at the beginning of induction. Now I have a sufficient opioid load on board at the end, so I don't need lidocaine. But that's for you to figure out.
So you're using that like the 1.5 mg per kg?
I am. And sometimes up to 2.
So when you said 150 milligrams IV?
IV. I use it IV, pre-induction. And I don't care that you know the dose, but why would I give it IV pre-induction? Right? Lidocaine is also used extensively in the OB suite. It's used extensively for usually one scenario. Okay? Now, I want you to think about this. Why would I have in my pocket on the OB suite 20 cc's of lidocaine mixed with bicarb, ready to go? Emergency C-section. Okay? What does the bicarb do for my onset? It makes it work faster. Okay? It decreases the onset. Right? Decreases the time to onset. Right? Make sure those words are right. But it's not used prolonged infusion. It's not used for prolonged infusion. So when you're reading these next slides, keep that in mind. It's one thing to use it continuously over time. It's another thing to use it acutely. One of the issues when lidocaine was used on the OB suite over time was fetal depression and this thing called ion trapping. Is the fetus more or less acidic than the mother? More acidic. So the fetus has more hydrogen ions. So local anesthetic, with this pKa being close to physiologic pH, finds its way into the uterus, into the placenta, into the fetus, and then gets trapped by that acidotic fetus. Can you all see that? So, if you were laboring and you gave lidocaine for an extended period of time, you could have significant accumulation of lidocaine with the fetus, especially if this fetus is stressed. But sir, you just said you're giving it for emergency C-sections. Okay. How long do you think it takes to get a baby out in an emergency C-section?
About 30 seconds.
About 5 minutes from time to a real emergency. 5 minutes from the time you call it to the time baby's out. And so in that time, there is not sufficient time for accumulation of significant levels of lidocaine in the fetus. Any questions on that? So if I run long-term infusions of lidocaine on the OB suite, I'm concerned with ion trapping in the fetus. Bupivacaine. Lidocaine, also known as Xylocaine. Anybody not heard that one before? Xylocaine. And if you're in Europe, Lidocaine. But you're not in Europe. So. Now let's talk briefly about Bupivacaine, also known as Carbocaine. Carbocaine. This one has intermediate duration, got a pretty quick onset, but you will not use this on the OB suite at all because this drug has even more problems in the fetus because the fetus doesn't have the enzymes necessary to break this drug down. The fetus, now there's dual ring structures on a couple local anesthetics, but for Carbocaine, Bupivacaine, for some reason, I don't know why, the fetus cannot break down this particular dual ring, double ring structure. And so it gets caught in the fetus, and now you have a depressed fetus. So because of liver immaturity in the fetus, that is a contraindication to the use of Carbocaine on the OB deck. Here are the doses for Carbocaine for your own purposes. Now let's move on to Prilocaine. Prilocaine is a lidocaine analog, so it has a very similar profile. But Prilocaine has a problem that another local anesthetic has. What local anesthetic is that one? Benzocaine, hurricane spray. And that problem is the synthesis of methemoglobin. Now, every year with Prilocaine, people love to mention its metabolite responsible for the methemoglobinemia, and that is O-toluidine, which in the body will cause the body to produce methemoglobin. So associate Prilocaine with methemoglobinemia, with O-toluidine, and guess how you treat methemoglobinemia? Methylene blue. So if I can use methylene blue to treat Prilocaine, I can also use it to treat methemoglobinemia from Benzocaine. Anybody here used EMLA cream before? Anybody know what the E and the M and the L and the A stand for?
Epinephrine, lidocaine.
Nope. Eutectic mixture of local anesthetics. Eutectic mixture of local anesthetics. Eutectic. E-U-T-E-C-T-I-C. Mixture of local anesthetics. And did you know that this was a complete accident that they found this? So, in someone's laboratory, you had the polymer Prilocaine and the monomer lidocaine. One was a liquid, one was a powder. And I think one of the research assistants, if I remember the story correctly, and I think I do, they dropped two of these vials, and when it mixed together, it made this jelly. And they went to clean it up, and they're like, wow, this is making my fingers numb. And so they started doing research on it, and now you use it as a topical anesthetic when you're going to do an IV insertion or something of this sort.
What does eutectic actually mean?
Eutectic.
Neutral, it's not accidental.
I don't know. Find out. It sounds good, though. I'm sure it has some appropriate name, but that's what EMLA cream means.
It means easy.
I know this mixes very easily.
Really?
Huh?
It means easy.
Usability.
Usability? Eutectic? So eutectic means fusibility, the ability of lidocaine and Prilocaine to fuse together. They should have called it ephemeral. No, I don't know. All right, finally, bupivacaine. Bupivacaine, you will use this one till the cows come home. This one and ropivacaine. These are going to be your two major long-acting local anesthetics. Your intermediate acting is going to be lidocaine. Your short acting is going to be chloroprocaine. Any surprises there? So on the test, I'm going to stress chloroprocaine. I'm going to stress lidocaine. I'm going to stress ropivacaine. I'm going to stress bupivacaine.
So again, could you, I'm sorry, back up before you put your stress on here.
Okay?
Chloroprocaine was your short acting, your intermediate acting was going to be your lidocaine.
Long acting is ropivacaine and bupivacaine. Now, what do you know about bupivacaine? Does it have a high or a low pKa? It's got a high, right? So it's relatively charged when it's infused, so it's hard to get through membranes. Makes it perfect for long infusions on the OB suite. However, not real cool if you're looking for a quick onset for an emergency situation, regardless of whatever the situation is. It doesn't have a quick onset. If you're looking for a quick onset, you better use lidocaine or chloroprocaine. But sir, chloroprocaine has a 9.1 pKa. Yes, but what are you doing? You're given a very high concentration. Concentration of bupivacaine that you'll use, so you can write this down. Chloroprocaine typically 3%. 3% solution, meaning 30 milligrams per ml. Lidocaine, typically a 1 to 2% solution. Ropivacaine, neuropin, we haven't got there yet, but we will. Usually given 0.25 to 1%. Bupivacaine, typically given 0.125 to 0.75%. 0.125 to 0.75%. Huh? Bupivacaine. Marcaine. So bupivacaine is also known as Marcaine. So many of you may know it by that name. Has a slow onset, relatively slow compared to lidocaine or Prilocaine. Has profound blocking ability though. Has a high protein binding capability. And has a relatively high lipophilicity, meaning that it's going to stick around for a long time. As well as that, it has 2 eyes in it. What does that tell you? Broken down by the liver. So it actually has to get into the plasma, be filtrated by the liver, and then excreted. One of the things, because it's very potent, it also is very toxic. And so your safety window, if you're looking for physical symptoms, may be very small. If you were to inject this systemically, your patient might go from, I'm not feeling too, to completely cardiovascularly collapsed without giving you the slurring of the speech, the ringing of the ears. So that's what that second line means. Whereas if I give someone lidocaine, they're probably going to be all right, but they're going to start talking funny, going to complain of ringing in their ears, that funny taste in their mouth, because it takes a whole lot of drug, lidocaine, to get the cardiovascular collapse. It doesn't take a whole lot of bupivacaine to get there. Bupivacaine, Marcaine, is associated with fast in, slow out kinetics. Yes, it has a slow onset, right? But relative slow onset, relative to lidocaine, relative to chloroprocaine. So chloroprocaine, you're talking about less than 5 minutes. Lidocaine, you're talking about 5 to 10 minutes. Bupivacaine, you're talking 15 to 20 minutes. That's still pretty fast. It's not too slow. But it's going to come out very, very slowly. So your duration of action is long. Right? Because if pKa is 8.1 going in, pKa is still 8.1 coming out. So once it gets into the cytosol, which is even more acidic than the bloodstream, there's more hydrogen ions to keep it bound. And it's got a high protein binding. So you can see how it gets in the cell and stays there. When you hear about cardiac arrest and local anesthetic toxicity, this is the drug that they're talking about. This is the drug that you're talking about. Now recently, there's been some success with LAST, local anesthetic systemic toxicity, typically talking about bupivacaine, with the use of lipid rescue. Anyone here seen lipid rescue? It's white, right? It's a lipid emulsion, 1%. They inject it, hoping that they create this theory called the lipid sink, where they soak up some of the bupivacaine in the plasma, creating a gradient, and hopefully that helps to help dissociate some of the bupivacaine surrounding the heart. It's in case studies, but if there's more than a few case studies, in some people's eyes, that's evidence. So you're going to see lipid rescue used to treat bupivacaine toxicity. Now, how did they find out that bupivacaine was so problematic? So a couple decades ago, they were using 0.75% routinely in labor epidurals. And if you remember the difference between an epidural and a spinal, what do you know it to be? Volume. The volume of a spinal is 2 cc's. The volume of an epidural is 20 cc's on average. So if I'm delivering bupivacaine at 0.75% concentration, that's 7.5 milligrams per cc. So what's 20 times 7.5? It's 150 milligrams. That's a high dose. And so they were seen in obstetrics with intravascular injection of this higher dose, these cardiovascular collapse cases. So in pregnancy, you can use it for spinal, but you cannot use this concentration for epidural. Can you use 0.5% bupivacaine for epidural? Yes. Can you use 0.25? Yes. You just can't use 0.75% in the laboring patient. Okay? We need a break, or should I keep? Break.
You take away you can use it for spinal, no evidence.
That particular concentration in the OB patient. Right?
Yeah. Another 20, 25 more slots to go.
All right, here we go. Okay, still talking about Marcaine, Bupivacaine. Let's go over some of the things that will augment toxicity. Acidosis. What does acidosis do once again? Hydrogen ions, which will then bind to plasma proteins and increase free-floating drug. That's right. So acidosis will increase toxicity. And there's a hormone in pregnant women that also will augment the effect of the bupivacaine and other local anesthetics. That's progesterone. Yep. Progesterone.
And why is that?
You tell me, and you'll be winning the Nobel Prize.
Isn't it Prilocaine is the parent compound of progesterone, and it's an inhibitory neurotransmitter?
It definitely has some GABA effects. It definitely has some sodium channel blockade effects. But pregnenolone definitely has effects that mimic several inhibitory processes. Progesterone, yes. So what does that tell you in the pregnant woman?
Stay away from it.
Not stay away from it.
Don't give less.
Give less. Yeah. Decrease your dose by a third or a quarter. And what is the beauty of an epidural? You can adjust it. It has a catheter. You can titrate it a couple cc's at a time. Right? So, we talked about mixing bupivacaine with other agents. It's done all the time. But what is the one short-acting agent that you mix it with that might decrease its duration? Chloroprocaine. So you routinely will see bupivacaine mixed in with chloroprocaine, or you will see it routinely mixed in with lidocaine. And again, why are you mixing a short onset and a long-acting agent? Right? One's short onset, but the other one is long onset and long duration.
To decrease your onset.
Right? So you want the patient to get numb quickly, and then you want it to last a good long time. On this slide, the point is isobaric spinals. Even though the Food and Drug Administration says that it's not recommended, it's not that you can't do it, it's just not recommended to do it. Hypobaric spinals, or isobaric spinals, I'm sorry. So this is the scenario. There's a formulation of Marcaine, 0.5% Marcaine, and on the vial it says preservative-free, and it says isobaric. That's the vial that they're talking about. If I give this isobaric spinal, where does it go? It doesn't go anywhere. It stays where it's at, it lasts a good long time, and it's very useful. And you will do this. You will give 2 to 3 cc's of isobaric Marcaine. The thing you have to remember is that the Food and Drug Administration hasn't approved this practice. But there's many things that we do that haven't been approved. One of the most glaring is stopping preterm labor. Terbutaline is not FDA approved for stopping preterm labor, but it's done all the time.
Sir,
Yeah,
can I ask a potentially dumb question?
there's never a dumb question.
Is that because we're in the military, or is that because as anesthesia providers we make decisions like that?
We make decisions like that, right? So is there anything dangerous to giving a preservative-free isobaric solution?
No.
Not if you give it appropriately. Yeah.
So in the Tetracaine case, can you get in trouble? I mean, if somebody comes back and
Well, here is it standard practice?
yes,
Yes, it is.
So you can use that as a backup.
With it's given within a reasonable standard, so it is industry standard. I don't know why they make such a big deal about the FDA approval, right? If they were so, you have to get FDA approval if you want to market it for a specific intervention, but it doesn't mean you can't use another drug for that specific intervention. You just can't market the drug that this is approved for this situation. That's really all the FDA does for you. It says, I can use this drug in this situation, and that's what it's marketed for. Like the hyperbaric marking, oh yeah, it's FDA approved because its market now is spinal use for hyperbaric solutions. Yeah.
does that have anything? I got it not necessarily our lane, but to do with reimbursement because I thought that at least for
Nope.
some drugs that there was no reimbursement
It's experimental.
If it's experimental, that's one
if
thing.
it's being used as an off-label.
Off-label, that depends on the insurance company. That depends on the insurance company, and if it's not standard practice, if it is an unusual standard of practice.
Thank you.
I might have missed something, sir, because I was typing. So the plain Bupivacaine in this case is isobaric?
Yes.
Okay.
The plain bupivacaine without anything added to it. Normal saline and bupivacaine is isobaric. The only reason I mention that to you is it is a very nice drug to use in the elderly population when you're worried about a sympathectomy. Because when you inject, think about what is responsible when a patient's laying on their back for the distribution of a spinal anesthetic. Gravity, voricity. So if I am isobaric and I don't find my way to the cardio accelerator fibers by dropping into that valley of the thorax, I stay right there. I have a nice solid block without a lot of hemodynamic alteration. Can you see that in your heads? That's what isovoricity does for you. But if you're hyperbaric and you're laying on your back, you're dropping down into that valley of the thorax. And what's on the bottom of that? Your cardio accelerator fibers. So when you get hypotensive, you also get bradycardic. And what is not going to work? Atropine, right? Atropine's not going to work, so you have to give a little bit of epinephrine to get that heart rate back up. All of those things will come back again. Yeah. Here we go. So, why won't atropine work? Okay. Baroreceptor is counting on the sympathetic nervous system, correct? And what is the sympathetic innervation to the heart? T1 to T4. And what is it putting out onto the heart? Norepinephrine, right? Norepinephrine. When we give atropine, what are the only receptors we're blocking? Muscarinic. And so we're hoping that the sympathetic nervous system is working when we give atropine. But what's the problem? What do we just do? We just block the sympathetic nervous system.
Radiant.
Well, yeah, or you'll be at a low rate. It's intrinsic 60, right? You may not go up at all. The problem is you have no sympathetic innervation because you blocked it at the level of T1 to T4 when that local anesthetic fell into the valley of the thorax. So you give atropine, it's useless because you need norepi. Because you're hoping that atropine's indirect effects work. Problem is, the indirect effects are shut down as well. So you have to give a direct acting agent. In this case, it'd be low doses of epinephrine for its beta-1 specific and direct effects. Better? I bet you that's a multiple choice question. Okay, Bupivacaine. This is going to be called Naropin. 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 Now this is an analog of both the drug Bupivacaine and Bupivacaine. It has physical characteristics related to both. Kind of a congener of both. And there's a reason for that. Is Bupivacaine as cardiotoxic as Bupivacaine in the adult? The answer would be no. So chemists tried to take advantage of the decrease in toxicity of Bupivacaine while combining the sensory capabilities of Bupivacaine. And then the compromise was this drug known as Bupivacaine. So it has structural similarities to both Bupivacaine and Bupivacaine. So that's what that red sentence is telling you. Now, when you give Bupivacaine, it has equal potency to Bupivacaine. So when you give Naropin, it's equally as potent as Marcaine. And there's some evidence to show when you use it for analgesic concentrations versus anesthetic concentrations that you get a better sensory block with less motor involvement. So if I'm using 0.1% of Bupivacaine and I'm using 0.1% Bupivacaine, which drug, according to what I just said, do you expect to have more motor block? Bupivacaine. I would expect those kind of questions. Bupivacaine is used extensively for epidural anesthesia, but you will not see it used commonly for spinal anesthesia. I don't know why. It's just not its thing.
Not of our guys around Germany had them. Just blocks.
Oh yeah, it's used for peripheral nerve blocks all the time. All of these drugs you can use for a peripheral nerve block. But does it make sense to use chloroprocaine for a peripheral nerve block by itself? No. Now, if you add it with something, then yes. Lidocaine. Now, this drug, for some reason, its unusualness, this drug seems to have a very high tendency to have a motor block and still have some sensory sparing problems. So that would be good. You can't move, but you feel a little bit. All right. A couple last ones and we're done for the day.
Sensory sparing.
Did you just say bad drug?
Not a very good drug, right? I mean, if you give enough, are you going to get a sensory block? Yes. But you got to give a lot. And then what's going to happen? It's going to last for a long time. And then, as it wears off, you're going to be able to feel things, but you're not going to be able to move. Right?
Sounds lovely.
Yeah, sounds awful. Is this ever used in real life?
So what drugs am I going to have you focus on? And ask a few questions about the others. Chloroprocaine, lidocaine. I'll probably ask you a couple questions about cocaine, because you will use those pledgets. I'm going to ask you about chloroprocaine, cocaine, lidocaine, Bupivacaine, Bupivacaine. Those are the ones you're going to make your money off of. I may ask you a little bit about Tetracaine. Why?
Powder.
Because it's powder and you might use it to deploy with. Okay. But the majority of the questions from the local anesthetic lectures are coming from those big four. And cocaine a little bit. Now, if you were able to efficiently and cost-effectively pull the L isomer out of Bupivacaine, you would make a lot of money. Because that part of Bupivacaine, the L isomer, or the S enantiomer, however you want to say it, whatever your flavor is, has half the toxicity of Marcaine with the same level of blockade, with possibly even better motor-sparing blockade than its racemic mixture. The problem is it's not very efficient to pull that out.
Just because of its cost?
Huh?
Does that mean the cost is just
Cost is inhibitory. That's why we're not using xenon either. It's cost. Xenon is the perfect inhalational agent. The perfect inhalational agent. It costs too much to make. Bupivacaine. Where have you heard that before? Cholinesterase test. That's probably the only thing you're ever going to use this for. All right. Emliprine. Here it is. It's a mixture of lidocaine and prilocaine. I don't know why I have this here. We've already talked about it. But nice picture for you to take home. Great. This slide here is for your own purposes. It gives you spinal anesthesia doses and durations. Now, if I say chloroprocaine in a spinal, because it happens, is that going to last a short time or a long time? Short. If I say lidocaine, intermediate. If I say bupivacaine, long. All right, don't get hung up on this many minutes, this many hours, whatever. I'm not going to do that. All right, this is just for you to look at and to look at relativities. Now, in a spinal anesthetic, what's your typical volume? 2 cc's. Okay? 2 cc's. The customary use and the voricity is right here. That should tell you when you inject it where it goes. All right? And you can look at the durations and get a relative comparison. That's all I want you to do there. When you add epinephrine, all I want you to do is just to get an idea of how long it will last, how long you can increase your drug effect. For example, let's look at giving lidocaine and using 5, not milligrams, fix that. That should be micrograms. That should be micrograms. That's a textbook error. So at the top, that picture where it says 5 milligrams per ml, change that. It should be 5 micrograms. 1 to 200,000. 5 micrograms. 1 to 200,000. Once you've made that change, take a look at lidocaine, for example. When you add 1 to 200,000 epinephrine, you're going to see how much longer you can extend that block. So lidocaine, you're going to get maybe another hour out of your anesthetic. And why is it extending the block? What is it doing? Vasoconstricting the site, having less of the drug absorbed by the blood. And how is it helping make the block deeper?
It's keeping the anesthetic.
Alpha 2. Right? Alpha 2 stimulation creates more resistance in the nerves. Alpha 2 is a GI. Does epinephrine not affect alpha 2 receptors? Sure does.
I think the sensory are compared to autonomic. There's
Alpha 2 is everywhere. Alpha 2 stimulation, when it's in a nerve, is going to increase resistance, make it harder for it to fire. It's going to augment your sodium channel blockade.
pre-synaptic?
Or postsynaptic, it doesn't matter. Tachyphylaxis. Promise you it doesn't matter in the nerves, pre or postsynaptic GI. Tachyphylaxis. This means that when you give a drug the second time, you don't get the same effect as the first time. When you give the drug a third time, you don't get the same effect as the second or the first time. So imagine you are, and the reason I keep bringing up OB is because this is where all the situation, this is all of the examples happen. You're on call 24 hours, and you're the OB anesthetist, and you start running your Bupivacaine or your Ropivacaine drip, and 6 hours later, 7 hours later, the labor is still progressing slowly, and now they're calling you because the epidural is not working. You look at the catheter, it's still in the right place. You test it with a different local anesthetic, and you want to make sure it's working, so you give 2% lidocaine, a surgical dose. You're like, darn it, I'm going to see if this thing's working. Well, it works with the 2% lidocaine, but all of a sudden, this Bupivacaine isn't working as effectively as it used to. For some reason, your body has adapted, or the environment has adapted, to make it less conducive for that Bupivacaine to block those sodium channels. Whatever reason it may be, it's not well described. But the thing to know is that that is called tachyphylaxis. The mechanisms underlying tachyphylaxis are controversial. In other words, no one knows why it happens. Is it a change in the pH of the environment? Is it an actual change in the domain sensitivity of the receptor? No one is quite sure, but it does happen in some patients. And it seems when you switch to another drug, the other drug is effective for a period of time, but then you have to switch again.
Could you switch back to the original?
Yeah, there have been case reports where switching back to the original drug gets an effect, but that declines over time, though. One interesting thing is that if you decide to give a little bit of ketamine, right? A, you're going to do two things. You may restore sensitivity, or you may restore the, what's the word I'm looking for? Maybe sensitivity of the local anesthetic for the voltage-gated sodium channel. But you're also going to scramble the head a little bit. So is it really the restoration of the sodium channel binding? But what else could you give for the non-pregnant patient that's got nitric oxide synthase inhibitor capability? And you probably don't even know this. You buy it at the convenience store all the time. Huh? Tylenol. Tylenol. Tylenol has nitric oxide synthase inhibitor capability. So the point there is, maybe this tachyphylaxis involves some type of central sensitization mechanism. Because think about what's happening. This is talking 6, 7, 8 hours. Over that period of time, can you alter your synaptic morphology? Over 8 hours? Sure you can. Over 12 hours? You absolutely can. These tachyphylaxis incidents that I'm talking about are long periods of infusion. And so if I'm blocking the sodium channel for a period of time, am I firing action potentials? No, I'm not releasing anything. Right? So this is that situation where I'm not releasing anything, so what does the body do? It tries to upregulate certain receptors to try to get out all of the glutamate it can. Maybe that's part of this. And maybe that's why giving a drug like ketamine or a nitric oxide synthase inhibitor, something that you know those two mechanisms are involved in sensitization, maybe that's why it works. That's just a speculation, though.
Ketamine
I'm not sure. I just NMDA blockade. We talked about differential blockade. That'll be up to you to review. We talked about critical length. We talked about vasoconstrictors. So that says milligrams again. Make sure you change that. Every time I switch from Linux to Word, it goes from micrograms to milligrams. Make sure that make sure that milligrams is gone. It should be 5 mics per ml. 5 mics per ml. That's a 1 to 200,000 solution. So Todd, I give this, why am I using this as a marker? When I say a marker, what does that mean?
As far as
I'm injecting local anesthetic into your body. What if I get this into the vascular system, that local anesthetic mixed with epi, what's going to happen? So I'm going to have hypertension. I'm going to have tachycardia. And a good rule of thumb is 20 beats per minute in 20 seconds. If your heart rate elevates 20 beats per minute in 20 seconds, maybe you injected that local anesthetic mixed with epinephrine into the bloodstream. So that's when you hear it called a marker. That's what it is. And why do I tell you as staff to always push your drug, your local anesthetic, when you're doing a peripheral nerve block or you're doing an epidural? I tell you, don't go over 5 cc's at a time. You want to see if you've injected it into the systemic vasculature. So every dose is a test dose. You're testing every dose that you give, 3 to 5 mLs, to make sure that you didn't inject it into the blood vessels. Because you've got to wait at least 20 seconds if you're going to follow that rule, 20 beats over 20 seconds. Yeah?
So what do you mean by marker?
I'm marking to see if I'm in the vasculature or not. So my marker is, if I'm in the vasculature, I'm marked. My blood pressure's going up, my heart rate's going up. That's what I mean by a marker. Because it'll tell me if it's in the vascular system. If my blood, that is the mark that it's in the vascular system. It's just a term that's used. I don't know any other term to use it as either. A mapper,
like
a
an
marker.
indicator.
Huh?
Indicator.
Indicator. There you go. It's an indicator. Now, when you're giving local anesthetic in the epidural space, you may not want to use, on the OB suite, you may not want to use epinephrine. There's 2 reasons. Epinephrine, does it have beta-2 effects? Yes. And does it have alpha-1 effects?
Yes.
So you could slow labor down, and then you could compromise fetal circulation with your alpha-1 vasoconstriction. Justin's getting ready to do a block. He's going to do a block on me, shoulder block. Why do I beg him to give me some Versed, especially since this is his first block? Because I'm like, this dude is going to fuck me up. Excuse my friend. Excuse my friend. Sorry about that. He's going to put it right into my vascular system. And I'm going to need that Versed to
He's going to miss it.
activate GABA channels should I need them, and protect my brain, increase my seizure threshold. So using a judicious dose of midazolam prior to a regional block is a good thing. And then I hope that he remembers to add his epinephrine as a marker and follow that 20 beats in 20-second rule. And every dose is a test dose, 3 to 5 mLs at a time. We talked about toxicity and protein binding. So anything that will decrease protein binding will increase toxicity. Sorry about that word, but it just came to my head. Now, for those of you that like to go out and eat Japanese, be careful of pufferfish. We spent all this time talking about sodium channel blockade. Anybody ever have pufferfish and wonder why their lips get numb? Well, this is why. The toxin that's in pufferfish will bind to the outside of the sodium channel permanently. And so if it is not made just right, you are a dead person. If you get a certain part of the pufferfish that has all of this toxin that we're talking about, right? The gonads and the viscera, if it's not cleaned right and you eat it, you are dead. And there is no reversal to this. So be careful eating pufferfish.
This is where money actually counts.
What's that?
Spending money on this actually matters.
Yes. The more you spend, the better clean. The more clean this pufferfish is.
You never know.
It says clams.
Oh, man.
But that's just for fun. I'm not testing you on that.
Go back. Why does it say clams?
Oh yeah, there's certain clams that'll have a toxin. So there's 2 types of toxin, right? There's this satotoxin, certain frogs, salamanders. Just be careful what you eat. Have a good day. I apologize.